I'll know from you. Keep the session open so people can actually review.
So welcome everybody. Thanks again for joining us for our SRMA Teaching Series. This is the 9th session in the series, and today we'll be looking at how to interpret results and writing. Delivering the session today is Niraj Kumar. He's delivered sessions a few times. For those of you who don't know Niraj, he's a current PhD student in cardiovascular science at the University of Leicester and previous medic at UCL. He's the founder and president of NMRA and has worked on over 50 projects. So just a reminder to please fill in the feedback form to get your certificate of attendance. I'll put the form in the chat partway through the session for you. And yeah, I'll hand over to you, Niraj. Thank you very much.
Fantastic. Thanks, Jacob. Hi everyone. My name is Niraj. Jacob's already introduced me amazingly. But so to get straight into it, to be honest, I kind of give this speech at the start of every lecture just for some transparency and to tell you guys a bit more about what we do with NMRA. But essentially, I founded NMRA in 2022. It's a non-profit aimed at giving students, doctors, young career academics a foundation in research. We want to give you guys a fair shot to get into research. We want to make sure that you're doing so in a way that helps you in your development. We want you to be learning, getting new skills, network, conducting projects with us. Basically anything that we can do that will help flatten the hierarchy and give you an easy route in that's working with you and your goals to conduct independent research. So going on to the next slide. We do this at the Academy every week, Thursday, 6 p.m. We're pretty much done at this point. We're on the 9th session, so if you've missed the other sessions beforehand or you want to go back over them, we are basically doing a chronological tour of starting off an idea from an initial idea, writing the protocol, going through to searching, screening risk of bias, identifying data and synthesizing it. We've covered meta-analysis the last 2 weeks with Connor, and now bringing it back to a full completion. We're going to talk about research write-up today. We're going to talk about results today. And then next week, I'm going to be back again talking about submission and just getting ready for journals and conferences and all that stuff. So hopefully this is all going to come together quite nicely. If you end up doing a project with us on mentorship, you'll be using most of these skills quite hands-on, which would be good. But even if you don't and you're just interested to do a project with us or something else of your own accord, hopefully this will give you an overview of everything you need to know. And as usual, any questions, any other projects you'd like to do with us, anything that we can do to help, just get in touch and we can figure it out from there. So without further ado, just to get into the teaching. So from the last couple of sessions, Connor has gone through how to do a meta-analysis. He's shown you with forest plots, how to create your funnel plots. He went through RevMan and R, so if you've not seen that, go back and check over it, but you'll get a good kind of hands-on idea of how to conduct the meta-analysis part of your paper. And but if you're going to watch on from here onwards, the idea is we've got that done. Now we need to fit that into your paper. We need to know what it means, and we need to be able to write up so we can actually get to the end of where we want to go with this. So just to go through this a little bit, this is something you may have seen already. This is it's a bit of an unusual meta-analysis, but I think it's important that you guys see a breadth of different things in literature. You're going to see a load of things in papers, and if you'd like to do something a bit unique yourselves, that would be quite good as well for your knowledge and your ability to answer different research questions. So this is what you call a single arm meta-analysis. Typically, when people think of meta-analysis, they're used to comparing drug A versus drug B, and that's obviously there's one arm of all the studies that have included drug A, and then the second arm is all the studies that include drug B, and the comparison is typically some kind of an odds ratio or risk ratio or hazard ratio between the two. Here, it's a little bit different. What we're essentially looking at is prevalence or likelihood of an outcome happening, but we're doing that for all the studies. So in this case, this is from a paper I did about 6 months ago. It's looking at survival after cardiac resynchronization therapy for ionotrope-dependent heart failure. So in this case, just to talk you through kind of the basics here. So when we say events, that is the number of people who exhibit the outcome of overall survival. So events is everyone who survived. The total is, as you can imagine, the total number of patients within that study, so the sample size. You don't really need to worry too much about weightage. The reason the weightage is different between these studies is because we use a random effects model, and essentially based on the sample sizes and the different study methods, it will generate a separate weightage for each study. The size of the red square for each study corresponds to its weightage. In this case, they're all kind of very similar. They're all about between 4, 5, 6% each, so there's not a huge variation, but you will get studies where one study might contribute to 50-60% of the weightage because it single-handedly contributes 50-60% of the sample size, and it's just the largest, most significant study in all of your meta-analysis. And at that point, you have to think to yourself, well, why is that the case, and how does that impact my results? Because if I take it out, possibly my results might be very different. But if I include it, the aggregate result will change with that. And does that variation, is there bias in that variation? Can we be certain that this is a good way to conduct the meta-analysis? Do we believe that this actually adds value? Those are all kind of questions you need to be thinking about. The answer will obviously depend on what your study is, but most of the time it's quite beneficial to have big studies in there because they are the most representative of a generalized population, and so they do have certain advantages. The end result, fundamentally, for all this fancy forest plot, is the stuff in bold. That's what you really care about. So we've got a total and a confidence interval. That's going to be your main result. So we've got the sample size, it's 334 people included in the analysis. And then the key result is here, 0.590. That's your survival rate. So for this outcome of overall survival, the pooled kind of result is 0.59, or 59.0% of people survive overall. And the confidence interval for the estimate is between 49.0% and 68.6%. So about 10% plus or minus, which is not great for the accuracy of your result, but with a sample size of 334, that's kind of what you're going to get. And someone like, as a reader, or yourself or any other researcher, your obvious thing to think about would be, why is it so bad? Why does that result have so much variation? And secondly, how does that even stack up to other therapy? Because if it turns out that doing nothing gives you a 50% survival rate anyway, you've got to weigh up that 9% survival benefit with, is this drug any good? Is this therapy any good, rather? So these kind of questions from your analysis result lend themselves quite nicely into your thinking clinically regarding what is the impact of what I'm doing. One other thing to kind of cover at the bottom of this one is heterogeneity. I'll go into that in more depth later, but just to flag it up now. So you have tau squared and chi-squared. Those are two different metrics which can be used to measure heterogeneity between studies. Degrees of freedom is just the number of studies, and then you need to add one, because that's the number of different things you're doing within your analysis. And so you've got I squared, that's your measure of heterogeneity, that's 69%, and P less than 0.1. So it's a pretty high amount of heterogeneity, and we're certain that it is very, very significant. So yeah, that would tell you that these papers are very different in terms of methodology and the way they're conducted, and that probably did impact your results, which is why a random effects model is probably appropriate. But regardless, you'd be mindful that studies are so vastly different that it is going to affect your result. To some extent, that is unavoidable, but as a researcher, you'd be smart to think about it, to know about it ahead of time, and to put in measures in place to measure it and to document it, which is why we did random effects model, for example. Going on to heterogeneity in more detail. This is from the Cochrane Handbook, and they've kind of just stated that, well, yeah, it's unavoidable because it's impossible to not have diversity within studies, because otherwise you just have the same data 10 times. But how you measure that is essentially just using the IQ, the I-squared score. Yeah, so you don't need to know this formula. Don't stress about it. Some very niche or technical papers, so for example, if you're writing a thesis on it, you might want to just state that and put the formula and explain it. But for a regular paper, just don't bother. It's not worth it. It's not worth the headache. But yeah, so the I-squared statistic is the most common way we measure this stuff. Cochrane kind of helpfully give you a rough understanding of what heterogeneity might look like. But as you can see, it does overlap. And the reason it overlaps is because you have to also think about what that means. So, for example, if you have a study with a really small sample size or a very big sample size, that value of I-squared is going to change in its meaning, because clinical and methodological diversity is not the same in 2 studies with 10 patients versus 2 with 100,000 patients. It's just because the statistical test has different power, and the impact of bias also changes. For example, if you have only 10 patients and because of bias, you say, well, 3 of them had an illness, that's 30%. But in 100,000 patients, having 3 more people or less people have that outcome barely makes a dent in your data. So the magnitude of something being biased is a lot more significant in lower number studies. And that's something that you have to think about. Most people kind of chunk this up into like 0 to 30, 30 to 70 or 75, and then the rest 75 to 100. So because we just do low, moderate, and high heterogeneity. Some people will use 4 categories like this, but there is a level of ambiguity in terms of how you determine I-squared statistic and how you do that. It's not something I think would be appropriate to go into at this stage. If you do end up doing a study with us or have any queries about it down the line, we can talk about it in more depth. But at the moment, I just want you to be familiar with what this looks like and be familiar with the fact that it's an unavoidable statistic. You must report it in your studies and have a brief understanding of why that might come about. So yeah, we'll leave that there for now. This is another type of meta-analysis, trying to show you some variety here. So this one has a mean, SD, which is standard deviation, and we're essentially comparing the QT interval in patients with anorexia versus a control group who don't have anorexia. And so obviously, because QT interval is measured as a time, so in milliseconds, it's continuous variable, and therefore it's going to have a mean. And then because it has a mean, we're also going to provide a standard deviation for that mean. So essentially, what we're doing here is just working out the mean difference. So this is the standardized mean difference. It's essentially going to tell us how much difference there is between the studies. So again, we focus on the dark bold column here, and we see that the difference is 16.93 milliseconds between the groups in the QT interval. And obviously, that is the 95% confidence will tell us it's between 4.5 and 29.3. So quite a big range, but definitely statistically significant, because that does not overlap 0. And if you want to be confident that you're absolutely certain with that, you check the test for overall effect. So because this is mean difference, we use something called the Z-score. The Z-score, so you report the Z-score of 2.68, and then you also report the p-value 0.007. It's less than our threshold of 0.05, so we can be confident that there is a difference in the QT interval across these 2 groups. Once again, we also have heterogeneity. So we've done tau squared, we've done chi-squared, and we've worked out the I-squared is 93% this time, so a really massive number, very significant level, and also very strongly correlated. We've got a p of 0.0001, tiny. So definitely significant heterogeneity and statistically significant heterogeneity, which is alarming. But again, you want to know about it beforehand. And yeah, so these are all things that you need to understand when you're doing meta-analysis, because otherwise you're not going to be able to analyze your data properly. But also these are things that your reader will want to know about, so you need to mention these within your manuscript. And I've kind of mentioned here, best practice is with z-score and the p-value with the mean difference to show the strength and magnitude of the association, because you want to show that there is a difference. There's a clear difference in that the anorexia group do have longer QT intervals, but also how much more longer and what's the significance of that. These are all important things to a reader. So it's good practice to report that. And I know it sometimes can feel a bit counterintuitive because it's already in the figure, but the text of your results needs to reflect that as well. I'm going to show you an example from a protocol so that I can specify that this is stuff that you need to think about beforehand and you need to cover within your analysis. So as you can see here, these guys, this is a protocol that I found on the internet for looking at CPR versus chest compression. Basically, they've said they're going to use RevMan, so they specified the type of software they'll use. They specified, well, they'll look at heterogeneity, and once they've looked at heterogeneity, they will then do risk ratio and 95% confidence interval for dichotomous data. So again, it's two groups separately and checking the difference between them. They will use Mantel-Heisel method, so that's just a method used for weightage for. You can use inverse variance. It doesn't really, the details again don't really matter at this stage, but it's just, Mantel-Heisel is kind of like the gold standard. That's the one everyone uses. But inverse variance is fine too. We will estimate the heterogeneity of the I-squared. If I-squared is less than 40, we'll assume it's unimportant. We've seen that in the Cochrane. That's what these guys said. If it's less than 40, it might not be important, so don't need to stress about it. But they are also deviating from what Cochrane said, because they're saying if it's more than 40, we're not going to go into whether it's medium or high risk. We're just going to say that it's significant, and we're going to use a random effects model to counter anyway, which they've reported it beforehand. They've shown that they understand the I-squared based on Cochrane. They've thought it through. It's fine. It doesn't particularly matter because they've thought it through, and they've pre-specified exactly what they plan to do. And the final manuscript should reflect that. However, if things do change, because maybe you find that actually you can't even do a meta-analysis, you don't have the sample size, because maybe you thought, oh, we'll find 10 papers for a meta-analysis, and then they actually find 3, and that can kill your project or make you force yourself to change what you're doing. So if you end up changing, just report it in your manuscript. As long as you're transparent and you're keeping on top of what you're talking about, it's never a problem. So this is just going back for the QT, going back to the kind of the QT interval stuff. This is essentially just an analysis that I reported, but these are just the write-up for the analysis. So as you can see, we have reported the mean difference, MD, confidence interval, and the p-value, and also the heterogeneity. So you put down all of these things. We also go into specifying the number of studies, the number of patients within the analysis, because that's quite significant, right? As a doctor, would you trust an analysis that has 200 patients or one with 200,000 patients, right? It's going to influence your perception and your interpretation of the result, because it's going to be more valid if more people are aware of it, and if it's got more people within the analysis, it might have better data quality. It might have more generalizability to different populations. There are, even the power of the stats will improve, so there's less likely to be random error. There are, notable reasons that a large sample size and large number of studies can be advantageous. Not even just because it shows you that this is something that multiple people have studied, and it reveals to you that this is an area where there is sizable confusion in the literature, and this one meta-analysis is pooling everything together to create one aggregate result. That's quite useful to know. So it's important to think about. But yeah, you can even see that variation exists within studies. So, for example, QTCB values are reported in 26 studies with 2,084 patients. At the very end, only 2 studies with 63 anorexia patients reported QT CFR. but this one is statistically significant. P equals 0.05. Very, very, very barely, though, because the confidence almost reaches 0. But you can imagine why there would be hesitance, or you'd want to be more cautious with this result because it has such a tiny sample and only 2 studies, which you have to then obviously go and check how they were conducted, whether you're happy with the results, whether you think they have introduced bias, and so forth. All the things that we've previously covered. So understanding the meta-analysis process helps you write it, because you'll know exactly what is important to a reader and you'll know how to report that effectively. But yeah, so that's kind of the results side of things. I'm going to kind of go through everything else as well. So talking about writing a manuscript, I'm not going to be covering writing an abstract today because I believe we're doing a separate session on that. It's a very big topic. There's quite a bit of detail to cover in terms of how you write abstracts for different things, how you write the conferences, word counts. So I'm not going to go into too much detail, but at this stage, I just want to illustrate on the screen that it is, when you read a manuscript, it's the very first thing, and it's meant to be kind of a very quick summary for someone who's not seen your work before to get up to speed on what you did it and why. But yeah, so this is kind of your standard layout. Most journals will do this, especially if this is writing meta-analysis. You might see small variations, such as they might say materials and methods for the method section, or some journals might say don't have a separate conclusion section, just make the last paragraph of your discussion a conclusion. But fundamentally, it doesn't change how you write your paper. It just changes the formatting and structure a little bit. So yeah, I will go through every single one in turn, and you kind of get an idea for what you're going to do. Obviously, with results, I won't cover meta. I'm going to try and talk more about kind of narrative stuff and structuring, so you get an idea of the rest of the result section. But yeah, so going straight into the introduction section, I always use this. It's kind of the idea of an inverse pyramid. You start broad and you narrow down. This diagram is slightly helpful in that it kind of tells you what's already each paragraph should look like. If you think about it in terms of 4-paragraph structure, you identify the problem. So it could be like a disease or an area that you're interested in. And then you go into the detail of what's been done so far. Then you go into, well, why are you doing this particular study? Because if there's already literature out there, why does your study need to be done? So you have to show the value that you're going to add. And then the last paragraph is how you're going to achieve that. So it's very specifically talking about the aims of your study and what it aims to contribute. So I will show you an example of this now, but you'll get an idea. You go broad and then you narrow down. So to start off here, this is a systematic review that I did 2.5 years ago now, maybe 3 years ago. This was about the neurosurgical care and neurosurgical training process and how it's been affected by COVID-19, particularly with a focus on LMICs, low middle income countries, versus HICs, which are high income countries. So to start off with, these are the first 2 paragraphs. We've started off by saying, the big picture problem is that neurosurgical care is massively divided, and there's a very big difference in how we do that and how we look at this between LMICs and HICs. And training is really important because that's how we aim to bridge that gap, but it's not been formulated properly. The second paragraph kind of ties into what is being covered in the literature, and we're starting to bring in our research questions slowly but surely, because we're thinking more about the pandemic. We're talking about restrictions that have been arising because of the pandemic, and we're also covering the literature and what it tells us so far. So we've covered, the changes to neurosurgical practice and how it's impacted us, and also therefore that it has reduced surgical training opportunities. It has reduced the education opportunities for both trainees and students. And lastly, just at the end of that, we want to say, well, actually, it's not all doom and gloom. The literature does report a few things that have been done, such as teleconferences, online learning, etc. But that's kind of the layer of the literature at the moment. Paragraph 3, we'll say, well, that's, but people haven't examined how this is disparate, how this has disparities between LMICs and HICs, and also it's just to address the fact that we need to understand this, particularly within the context of a pandemic, which has obviously affected the way we think about these things and our logistics and our management of training. So there is still a gap in the literature, despite what we've said in paragraph 2. And then the last paragraph say, well, in order to address this gap, we're going to do a systematic review. And we're going to do it in order to assess impact, to assess alternatives to training, and we're doing it particularly to identify solutions and to prevent things getting worse when COVID is not over yet. So we've kind of nailed down exactly how this study is going to add value and in what context it aims to achieve that. That's genuinely it. We've only written 4 paragraphs here, and these are very simple. Some studies will write more. That's completely fine. Because to be honest, in the context of the pandemic, at this stage, we were writing in 2021. There was not too much of literature available. Hence, we only have 6 references up to this point. But if you can imagine, you're doing a study on, a more popular drug that's used for something like diabetes or something really popular, there might be a lot more literature out there. And so you need to be very specific on what has been done and where exactly your literature fits in within this enormous field. So this is a simplistic example, and I'm trying to warn you that it suits my purpose to teach you guys, but don't necessarily replicate this exact formula and the same length and structure perfectly every time, because sometimes you will need to go into a lot more depth. And that's a good thing, because if you cover that depth, your reader will benefit, because they'll know exactly what you're up to and why you're doing what you're doing. So that's that. The method section, I've covered, I and other lecturers, I should say, we've covered this in a lot of depth. We've covered eligibility criteria, we've covered search strategy, we've covered screening, we've covered data extraction, data management, we've covered risk of bias, we've covered data synthesis and meta-analysis, which isn't on the slide, but we have covered in each individuality every single step of this process. So it's just a case of what I want to do is just help to put it all together a little bit, and you'll start to see a method section of a manuscript come together from that. So to start off with, the very first things you want to do is you're going to talk about the context of how you started to do this manuscript. So the initial things we've said is we wanted to cover the search strategy. So where exactly do these articles come from? We've said for this particular systematic review, we've said, well, we're going to look at a search covering the relevant terms, and we're going to do it in line with the Prospero protocol that's pre-published. So the very first things that we did when we were doing the systematic review, writing a protocol and identifying a search strategy, those are the first things that we report in our method section. And it is deliberately done, in my opinion, in a chronological order, because what that does is it gives your reader something very logical they can follow. Because if they're going to again, the example I always give is let them redo your work. If they're going to redo your work and verify it, they can then see that you first did a Prospero, then they can see that you did a search strategy and you searched from these dates, and if they followed those dates into the Ovid and Medline and all these different databases, they should end up with the same outcome, i.e. the same papers that you did, because you copied it. It's also really good to mention that we've covered here that the systematic review was designed, conducted, and reported with Prisma. So Prisma are essentially a set of guidelines or recommendations that are relevant to almost all systematic review meta-analyses, and they will guide you regarding how to conduct your study. And there's also a really helpful checklist. Some journals mandate that you kind of fill out the checklist and put specifically on the checklist where each item was located within your study. It is good practice. It's really helpful. It will guarantee that you don't miss anything, so you'll have a very thorough, very high quality meta-analysis, but it is not mandated by 80-90% of journals. So it's not a requirement. I think it's a really good practice and helpful to do. You'll also really notice that we're being very specific We're telling the reader that we did it on this date, we did it with these terms as in following this specific protocol, and all the things that we did are available in the appendix. So again, anyone who wants to replicate your work should be able to do that exactly based on what you've done. And if they can't, you were not specific enough. That's the simple truth of it. So yeah, we've covered the search strategy, started the initial things. So the next thing naturally is, well, which papers of those would you want for your systematic review? And that's where you need to identify and specify your inclusion and exclusion criteria. So you can then use that as a framework by which you will specify and screen through the papers you really need for your systematic review. So we're going chronologically through what we did and just following that through. The next thing, naturally, as you can imagine, is screening. We've called it study selection here, but it's the same thing. It's screening as ever. It's done by the inclusion exclusion criteria, and it's done in 2 stages by 2 authors independently. So we do title and abstract, and we do full screen. And then there's a third reviewer who can break up stuff. If things get confusing and someone's, we've got differences in opinion, the third reviewer steps in and they do a tie break. Simple. It's all stuff we've seen before. It's nothing complicated. Here, data extraction and risk of bias, kind of like my lecture, are merged together, but that was purely out of coincidence because we got the data for the data for the data extraction, and we did the assessment at the same time, so it's fine. But yeah, so essentially we reported same as usual. Two reviewers do this predefined Excel spreadsheet. We picked out. We tell you what we've picked out. So practice guidelines, relevant recommendations, data that was needed for quality assessment as per the risk of bias tool. We specified what the risk of bias tool is. I think that's just helpful. It's good practice to kind of show, because the agree tool is very specific. It's only used for appraisal of clinical practice guidelines. It's not something you'll see every day like Cochrane risk of bias. So it's important to cover because most readers might not have ever heard of it. So it's good to cover. Data synthesis, that's just how we go from data extraction on a spreadsheet to how we go and write it up in a manuscript, how we'll put it together. Because this is a guideline study, there's no meta-analysis, there's no data. All we're doing here is we are praising the guidelines with agree, scoring, and we are going to tabulate and synthesize the key recommendations and compare them. So all we're really doing is just putting down in table and word form what the recommendations were and who made them, and in the discussion section we'll be able to elaborate on why. It's very simple. There's a reason it's only 3 sentences, because quite frankly we didn't do that much. But yeah, that's it really. It's just remember, whatever you do in the process of before you write up, make sure you get all of it down and you'll be fine. There is not too much that's complicated with method section. It's to be honest, it's something that I like to do near the start of my manuscripts, because when I'm writing up, it's the stuff that comes to me most easily because I literally did every single step. I'll know what I did, I know how I did it, so I can just write that up the most quickly. I don't often even need to make any references. I don't need to go and look up anything. Whereas, introduction, you might need to go up and look up previous literature. Discussion, you definitely need to look up previous literature. So as you can imagine, those sections require more thought process, more time, more research. This stuff is essentially quite literal. It is literally what you did. Results. I'm not going to go again to the meta-analysis side, but we will just stick with the basics. So essentially, we're going to describe everything we said that we would describe within the method section. So initially, we're going to talk through the screening process and what papers we included, where they came from. We're going to talk about the studies particularly. If you've been through my data extraction and synthesis lectures, you'll know that I talk about kind of table 1, table 2, table 3. Table 1 is always your study characteristics. Table 2 is your patient characteristics. And table 3 is your outcomes. Obviously, you don't have table 3 if you're presenting outcomes as meta-analysis, because you'll just do the analysis. But as long as you have a structure like that, which clearly delineates all the work you're going to do and what you're going to cover, you can't go wrong. So yeah, the key thing to cover in those is just being straightforward and making sure that you're actually synthesizing results, but not commenting on them. It's not appropriate to comment on results in the results section, because that's what the discussion section is for. And this is where I think some people get quite confused, because when you do essays or other projects like that, thesis, for example, it can be quite easy to kind of say, well, this was analysis of 200 patients, and the analysis was, I don't know, an odds ratio of 5, the confidence interval of 3 to 7, which we believe adds bias because of the small sample size. It's easy to kind of add in personal opinion and your interpretation, because that's what would have been marked on favorably in essays and things. But in academic writing, it's not appropriate, and it's something that can be a little bit of a switch in thought process. Here, it's just synthesis, description, and leaving it alone for the discussion section. So just to kind of show you an example again, this is a study that we did on neurogliomas. And this is a few years ago. So essentially, we have the Prisma diagram. If you've not seen this before, it is literally just a run through of your screening process. So you identify all your papers, your databases, you remove duplicates, you screen for abstracts, screen full texts, and then these are what you keep. That's it. And at every stage, you tell people why you removed the studies. That's it. And so what we've done in the text is essentially just summarize and reflected what's in the diagram anyway. So we've said we identified 2,852 articles, which is there on the first box in the Prisma diagram, where we've told you that we have identified duplicates, which is again in the second box. And we've also mentioned that we did 178 articles for abstract, 89 at full text, which is here, and then 27 were at inclusion criteria. Once again, you'll notice it's important to kind of give an idea how many patients were in this analysis, so 1,985 patients, because again, that gives you an indication of the magnitude of the analysis, it gives you an indication of what to expect, and it kind of steers the direction towards you doing analysis and considering these potential biases that will arise. But essentially, there's naturally going to be overlap between what's in the figure and what's in the text, but that is by design. You should be re-reporting the key essential details, but you're doing so in a way that doesn't take away from you're not reporting every single specific thing in the figure, because otherwise what's the point of it? And you also notice we did cite the figure with figure 1, so people will go and read it and they'll get everything that they wouldn't have seen otherwise. Fine. So this is back to the neurosurgery one. This is more for like the kind of narrative synthesis side of things. Narrative synthesis, obviously, if you at the data synthesis lecture, I went through kind of thematic analysis, how to do it, how to come up with themes, and making sure that your themes line up with answering your research question. That work that you did at that stage essentially builds into a very clearly structured result section. And to give you an example of how we did that, I'll just talk you through this. I haven't put the whole result section in because it's long, and I don't think that I want anyone to read that particularly just in this lecture time. But it's essentially structured as per how we want to answer the research question. So we wanted to cover neurosurgery training for trainees, so like residents, and also for medical students. And that's why we took all the literature available and we split up the results as per the themes. So we had the first theme being trainee education, second theme was barriers and solutions, the third one was medical students education, and last one was their perspectives on the change in education and how it impacted their mental health. But then obviously within that, trainee education is a massive area, right? It's just a whole thing that covers every single aspect of the training, from operative time to them being able to access resources online versus not having as many opportunities to be in hospital for just training and being around patients, there were so many changes that occurred that it's important that we analyze each individual section as per the literature that we have in front of us. So, for example, in this case, one key theme that arose was practical skills training. So we've talked about, well, residents don't have as much OR time, they don't have as much time to subspecialize and learn, hospital management caseload. They just don't have the opportunities. And particularly, things that have changed is for example, things that have changed particularly is elective procedures have gone down, and obviously some people actually, there's variation between what LMICs and HRCs perceived, which again was one of our research objectives. So we've kind of specifically gone into that detail and said, well, for example, 62% of neurosurgical residents in a US survey didn't believe that it would make a difference on their surgical abilities, but in LMICs they said actually it would really make a difference. 75% have said it would have a negative effect. So what that tells you is, obviously, you start to think, well, is that variation because people in the US think they can compensate with other types of training, or what's going on? And those themes helps you to assist in understanding your research question better, and also gives your read a lot of context about what's going on there. And that is really beneficial because you're laying out the full picture for them based on that literature. And that synthesis of, I think we had 30 articles in this manuscript, into a few paragraphs, is what is the art of a good research project, because you're condensing so much literature into its key elements that are important, and you're nailing down the key themes, the key research questions, and you're specifically telling people why they should care about this information in front of them. So that's very important. So yeah, just following on from this, there's practical skills training. Then there's also, the fact that people didn't actually get to be on neurosurgical wards. They got shifted to COVID wards. And, because of that, they didn't get to go to see as many patients, and, it took away from their training time. So that's an impact that came up in literature and is relevant to these patients. As you can imagine, however, it's not all doom and gloom. So something that was flagged up was that because these guys were focused on elective cases being cancelled, they ended up doing more research and doing more remote work. They focused on other things. And in some ways that can be beneficial, right? Because you're making the most of the opportunities you have, and you're developing other skills that will also benefit you, because as a clinician and a surgeon, these are other things that are important to you. So as a researcher doing these projects, I'm thinking broad picture, and these themes allow you to then frame the narrative and the research question accordingly. That's really beneficial. But without good data extraction and good synthesis, it's not going to make sense. So that's why I really strongly encourage that you go back to that stuff and go into it in as much detail as possible. And then this write-up becomes a lot easier. But I just wanted to kind of specifically go through this example because thematic analysis is challenging. This is kind of breaking down what's in a paper and then what's important to our research question. And that can get twisted because, again, people start to interpret things. People don't exactly always get what they exactly want out of the papers. It's a complicated area. But it's something where, with the right navigation and DAGs and things like that, it does become easier. Yeah. Another thing that I kind of re-raised was, well, okay, fine. People are no longer doing practical skills training. They're instead doing online teaching. And that's something that's changed. People are doing online lectures, online courses, and that's something that is encouraging people to learn more in an era of remote social distancing, things like that. So, yeah. For example, but however, in line with our research question, we also identified key disparities. So in North America, 98.5% of respondents in the studies said that they could do their program online. But in Africa, in studies on the African continent, it was 43.9%, and in India, 61%. So potentially what we're revealing here is that there are disparities that are leading to people missing out on neurosurgical education. And that's stuff that we are able to synthesize by looking at all these different studies. So you get an idea based on the references, right? So 8 to 12, there are these, we're talking as a general here about training in 1, 2, 5, 6, 7, 8, 9, 10, 11 studies. And then obviously we've gone here to more geographic details. So that's also really important, right? And here, these three main studies are the ones that compare both high-income country and low-income country, and they reveal this pattern out of the 30 papers that we included. Sometimes there's only a very small subset that help you answer your question, but those are the ones that get the most attention because they're the ones that are helping you prove your point. But yeah, so again, this is stuff that is a little bit abstract. It's not something you can easily get your head around. My kind of strong recommendation is to read as many of these papers as possible, because the more you read them and you see how they're structured and you get an understanding of why they've done the particular things they've done, it becomes a lot easier to then replicate that and use the same methodology again. But yeah, the next thing I need to cover with you is discussion sections. These are probably the most significant part of any paper. A discussion section, I kind of put here, there's like a mini paper. That's pretty much the best way I can think of describing it, because you're basically going to start from covering why you did the study and your most salient results, and then you're going to go through other studies in the field that have been done, comparing and contrasting your work. You're going to show they had insights and you had insights, and you're going to start to synthesize those to develop a way going forward, and essentially provide people reading your paper with little nuggets of, these are future studies that can be done, these are implications of future practice. You're going to be kind of laying the land for what is coming next. And then the last thing you want to do is strengths and weaknesses. Essentially, I like to think of this as a chance to rebut the comments that might come up from peer review or from people reading your paper, because there are some very glaring, obvious things that come up with meta-analysis, systematic review, that you'll see again and again. I'll go through those when I show you 2 examples. I've put here just in case your journal asks, but lastly, give a conclusion and a summary of your main work implications. That's if you don't have a separate conclusion section, but I've also done a separate conclusion section at the end just to show you what it looks like. But yeah, if your journal wants it to be all put together, just put it together. It doesn't really change anything except you lose the conclusion subheader. So you guys, it's not a big deal. But yeah, so to start off with, this is just the overarching, again, this is the CRT paper. It's just an overarching thing that we cover in the first few paragraphs. So we've said, well, listen, this is the largest meta-analysis for CRT, and the most relevant findings are as follows. So CRT is beneficial for survival, interprocedural mortality is low, and it helps with survival, NYHA class, readmissions, and also for patients with left bundle branch block and left ventricular dilatation, there's additional benefit for these guys. So we've essentially summarized all of the key findings from all of those different meta-analyses in 1, 2, 3, 4, 5, 4.5, 5 points. That's it. So that really kind of nails down the key essence of why we did this project and what it achieved in a paragraph. And then we've gone on to say, well, let's see what's out there, right? So end-stage HF prognosis is limited. There's some scope about other people using LVAD or medical management, but these have pretty poor survival. It's 6% as a whole, and then it's 25% in the rematch trial. However, in the discussion section, you can start to raise these points. So we could say, well, actually, these patients weren't all of them had inotrope dependency. So can we be certain that it's an appropriate comparison? But yeah, so you start to kind of use your brain critically and think through these problems now. So what we're saying is essentially here is that, well, you can do CRT. We either have LVAD or heart transplant, and you can consider these as alternatives because that's what the guidelines say. However, they have their own challenges and their own limitations. So in context of these, we can then talk about where CRT fits in, right? So we can say, well, CRT is less invasive, has low risk of complications, and a relatively high level of safety. So as a result of what we've done, the future lay of the land is, let's look at CRT more seriously and not just think of heart failure as the main, or LVAD as the main way to do this. We have a potential new therapy that, based on our meta-analysis, is actually pretty decent. So we're building up that evidence base, and we're showing, in line with our research question, the future of where this might go and the benefit that this offers to clinical practice. We've also covered kind of differences by patients. So, for example, people with left renal branch are more likely to respond to therapy, and that's actually quite beneficial because we know that CRT can do this. It has a particular mechanism by which it achieves that. So that's also very important for clinical practice, because what we don't want is that a reader thinks, oh, CRT is amazing, we'll just give it to everybody, because that would be poor practice. As in line with evidence-based medicine, we need to acknowledge that this therapy will respond differently in different patients. And if we have data that will inform that, we want to report it as clearly as possible, because it's in line with our duty as scientists to put down all the evidence and to show the direction in which the data takes us and how we're going to structure this. But that's pretty much it. It's mostly just about laying out your argument. A lot of these situations, when you do these kind of discussion sections, in your head, you need to have a point that you want to make across. So with us, it's very clear. It's, let's look at CRT more seriously. And at the moment, it's not. We focus on other things, but that's not necessarily fair because CRT is actually good in comparison. So we've laid out the land of, well, at the moment, this is the current survival rate and the current alternatives to therapy. It's not great, and we're not sure about it, and CRT is and should be part of that conversation. So we have a very specific way of how we want to introduce CRT, and a very specific way of how we go through and navigate all the literature. And, what we have to recognize here is that at the end of the day, as a scientist, you're going to answer things based on your research question and your research aim. So as long as you're doing that, that's what you need to talk about within your discussion section. But also, we need to identify and point out things that are different, right? So, for example, we have specified that, well, these studies had lower survival rates than we did, but they're not the same patient group. And so we need to bear that in mind. And it's very important that we raise things like that, because critical thinking and appraisal of literature and analysis of where the literature takes us is what makes a high quality discussion section. It's important to be able to refer back to other trials and to refer to guidelines and to kind of navigate your way through that. But fundamentally, we have a very specific direction which we want to go, and we stick to that. The next thing I'll go through is strengths and limitations. So all of these biases will come up at some point in the teaching series when we do meta-analyses or just data extraction, identifying papers. As you can imagine, all of these are biases because they shift the direction of your analysis and the results in a particular way. So as you can imagine, things like small sample size is going to affect the power of your analysis. It's going to affect the impact of potential bias. Study design is going to impact bias because an observational bias may occur in observational studies. Clinical trials benefit from things like randomization, so there's an equality between both groups. They benefit from blinding, so theoretically neither group of patients or researchers know who's involved, and they're not going to impart their own personal biases onto the results of the study. There might be differences between included patients because groups might be different, so they might have different outcomes and different responses to drugs and therapies, which will again bias the groups between one and the other. There might be differences in how we measure outcomes or define them, and obviously that's going to change the result we record, and then that might lead to differences between groups. And the last thing is differences in study environments. So you might find that there's differences between the geographical location in which things are done, which obviously might affect it might affect any of the other analyses as well. You might find that, like, for example, if you're doing surgery and surgery is done in different techniques in different countries, that's going to impact outcomes, because you might find that actually, the skill of that particular surgeon impacts the way it's done and the outcomes, because it's not comparable between groups anymore. It might be cultural, because you might find that things are measured differently in different cultures or recorded differently in different cultures. One example I can think of off the top of my head is I'm currently doing a study on ethnic disparities, and the way we measure and think about ethnicity varies between Africa and Europe and in America. So we're not doing a fair comparison anymore, and that's going to impact the results we record. So these are just kind of the big things that come up. There are obviously hundreds of other biases that can be important to us, but for brevity, I'll stick to what's most likely to come up, and then if there's particular niche things that you see, or particular things that come up within papers, you can go to that privately in our own time. We can look through that. But to start off with, this is a meta-analysis we did looking at essentially skeletonized versus pedigled coronary artery bypass grafting, and we've recorded essentially all the main biases here. So the first one is that, well, the study designs are different. They have different qualities. Some of them are prospective, some are retrospective. The design is different, and so when we do meta-analysis, the bias within each study gets carried over into our meta-analysis. That's an limitation. The second limitation is the definitions of graft failure and the difference and that will lead to differences in how we measure the outcome and how we record it, which could then affect our results. We've also kind of somewhat covered sample size, because we've said, well, graft failure was only reported in a limited number of studies. So it's potential that variable will not have nearly as many patients as the other analyses might have, which is going to obviously limit the usefulness of that analysis compared to the other ones, or just in general. The harvesting of the IT is operator dependent. So that's obviously the environment, because different surgeons and different hospital techniques may differ, which will lead to difference in outcomes. And the last one is, well, studies are performed in different countries. So, again, they might have different practices, different ways of doing things. The last one is a little bit tricky. That's not in my list, but it's a study level meta-analysis. I don't believe we've covered individual patient data meta-analysis. It's not really in the scope of this teaching series. Essentially, what that means is you would contact all the authors of the individual papers, ask them to give you their raw data. You would then collate that raw data into a massive database and then run the analysis with their raw data. Because obviously, if you do an analysis based on study level data, it's already been pre-processed. You don't always have all the variables, and so there are limitations as to what you can do with that data as well. You're kind of assuming on all of the biases and the processes they've done to that data, and you just have to deal with it. So it does limit clinical variables you can include. It does limit the potential to investigate those relationships. It's quite a niche thing, and IPDs are not done commonly, but they do add a lot of statistical value. So they're very highly regarded. Some of them you might see in really top tier journals, such as the Lancet, New England Journal, things like that, because they add a lot of value to the literature. But yeah, essentially, as you can imagine from this, anything that kind of limits your ability to answer your research question, anything that's going to take away from the strength of your meta-analysis systematic review is a potential limitation. And, like I said before, think about it as if you're flagging these up before your reader will, or your peer reviewer will. But yeah, this is another one that we did from the study. Again, the main things, so we've combined future directions here. That's something that some journals will ask for, some won't, but some people would like to talk about anyway. It's quite helpful. So yeah, the things we've specified here are limitations being sample size, lack of RCT, so all the studies are observational. We tried to find case control studies, but that didn't really help. And because of that, obviously, patient populations are included they have differences. Some of them have differences in NYHA class. Some of them have differences in age and ejection fraction. So there is variation there, and that does impact the result we get. So in that context, in the context of these limitations, we start to think of, well, what's next? And the next natural thing that comes is actually we probably need an RCT to prove the point of how good CRT genuinely is. It would also be helpful to kind of think about potential subgroups of why it's going to help. So, for example, we in our paper we found that left bundle branch blockage actually helped people's response to CRT. So maybe there's a context in which we should think about, looking at therapies that address that within the context of CRT, and that's a potential research gap that someone else can pick up on. So essentially, what we're doing is we're seeing what we've left behind and we weren't able to answer due to limitations or the lack of scope in our work, and then where do we go with that? And that develops into a future research direction. But the last thing I want to cover is conclusions. I just made it a separate thing because some journals will. It really doesn't really matter. Either way, it's simply a one paragraph summary of your take-home message of what you did, what you found, and something for the future. It doesn't need to be very complicated. And to be honest, it's just a summary and a follow-on from your discussion section, because you would have already covered all these things. You have already in your discussion section covered what you found. You've already covered the lay of the land. You've covered what's wrong with your study potentially in terms of limitations. And you've also covered where future literature should point to. You're just summarizing what is maybe 1,000 or 1,500 words into a little paragraph. It's not groundbreaking. And I'll show you that with an example. So see, our conclusion here is CRT it may be an alternative to LVAD and HT because it's less invasive and it has fewer risks and it's helpful. There may be benefit to patients with a left bundle branch block, but given that there's limited data, we should do RCTs in the future to identify and determine its widespread implementation. That's it. So we've summarized the question, we've demonstrated why it's important to the reader by telling them what they should think, what they should do about it. So in this case, it's an alternative to LVAD, and it's really beneficial, particularly in those patients with left bundle branch block. And we've highlighted that future RCTs are needed because they've never been done before, and that's a limiting step in terms of how we perceive this and its future implementation. So let's fix that. And that's pretty much it, really. It's not groundbreaking. It's not adding anything new. It's just a very, very brief summary. This is probably not even 100 words. It's, it's a tiny paragraph summary, and that's all you need to do. But that should be, and it is, everything I need to cover for today. Do we have any questions?
I don't think we have any questions in the chat yet.
There's a question. Hello, are all the presentations available somewhere to revise? Yeah, they are. The recordings always get uploaded. That's fine. But otherwise, if there are any questions that you want to ask me now, go for it. If not, I'm happy to take emails or questions otherwise. And a fair chunk of you will probably end up dealing with this stuff directly in the mentorship program, at which point we can just deal with that together. So that should be everything. And I'll stick around for a few minutes if you want to talk to me about stuff. But thank you for listening.